has been considered as a fulfilling, natural experience that is emotional to mothers. A high percentage of women developed a lot of complications, and some of them may even die in the process. I have been impacted. 4 years ago, I lost my younger sister from pregnancy-related and childbirth issues. Difficult things. But then again, there are certain things that you cannot explain, right? But just to accept that. But then again, that you have lost one does not mean you shouldn't keep making efforts to prevent the death of the next one. So that's how it works. All right. So next slide, please. All right. So what are the issues when it comes to maternal health? These issues, right? So if you look at globally, it's estimated that about 287,000 women died from pregnancy and childbirth-related issues in 2020. This number has basically represents significant improvement. In previous years, it used to be higher than this. But because of this package that we're talking about, the number of deaths, maternal-related deaths from pregnancy and childbirth has significantly reduced. So if you look at these numbers, what it means is, if you do the math, what it means is somewhere in the world, let me not say somewhere in the world. So 99% of most of these deaths are in Africa and in South Asia. So remember, we're in Africa, right? Nigeria. And interestingly, Nigeria is one of the highest contributors to these numbers that we're seeing. So a lot of mothers are dying in our country. Now, going back to that number that I said, 287,000, if you do the maths, it means every 2 minutes, a woman dies in Africa or in Asia due to pregnancy or childbirth. It's a very, very serious issue. The countries that contribute the highest numbers, Nigeria, India. So if you look at 1/3 of these 278,000 that we're talking about are happening actually in Nigeria and in India. So again, today we hope to look at what are some of the risk factors. What are the common causes of this maternal death? What are the factors that predisposes mothers to dying or suffering serious complications from a natural process of bringing forth life? Next slide, please. All right. So if you look at the slide, I have like two sides. One, we talked about direct causes, and the other one, we talked about indirect causes. So for the direct causes, we have excessive bleeding. So bleeding can happen to a pregnant woman while she's pregnant. It can happen when she's giving birth. It can also happen after she has given birth. So again, that underscores the importance why we talk about the pregnancy period, the childbirth process, and then the period immediately after the delivery of the pregnancy. So when a woman gives birth, that's not the end of the issues. Things that you do not anticipate can happen after she has given birth, right? So the other thing is infection. A lot of deliveries in Africa and Asia are happening under unhygienic conditions. Women don't go to the hospitals to deliver. And then I'm sorry to say, sometimes even in the hospital, people don't pay attention to septic processes that will prevent infections from happening when mothers are giving birth. If a woman gets infected during pregnancy, it's likely going to get a very, very serious disease that may cost her life. So the other thing is has to do with high blood pressure during pregnancy or immediately after pregnancy. So pregnancy, so sometimes it might be high blood pressure before the woman even had become pregnant. Sometimes the woman might not have high blood pressure before she gets pregnant, but the pregnancy induces a high blood pressure, causes high blood pressure for that woman. And there's a name we call that particular situation. Some of you might have heard about eclampsia and preeclampsia. So those are the medical terms for pregnancy, high blood pressure during pregnancy. So for such women, when they are not pregnant, their blood pressure is normal. When they get pregnant, usually halfway through the pregnancy, the blood pressure tends to go up, and it has negative implication for both the mother and the unborn child. So the other thing that we might have to look at are issues around unsafe abortion. Sorry, I use the word abortion because that's the right medical term. I know people might have some other thoughts when you see the word abortion. Medically, we call them abortion. The things we call miscarriages, we call abortion, especially when they happen before the pregnancy is 6 months old. That's 28 weeks in our own environment. In the developed world, their own is as low as 20 weeks. And it's 20 weeks because if a baby comes out at 20 weeks, they have the facility to, keep that baby alive. In our settings, we do not have the facility to manage a child who comes out at 20 weeks of age, of gestation. So that's why ours is at 28 weeks. We can manage keep babies alive once they get to 28 weeks. But that also you have to make a lot of efforts, right? So the other thing has to do with issues around obstruction of labor. So with all the attendant complications that we'll call. So there are other things that are indirect causes. So these ones that I mentioned are direct causes. The indirect causes, you have low blood level. The woman does not have sufficient blood while she's pregnant. She goes into labor with low level of blood. When you deliver, there's still going to be some loss of blood during delivery. So that further compounds her low level of blood and might cause a lot of negative health issues for the mother, but also for the baby. Then you have issues around infection, repeated infection. Malaria, it's common in our environment. It's not good for a pregnant woman to be exposed to infection with the malaria parasite. Malaria parasite will destroy red blood cells. Destruction of red blood cells will cause low blood level. If already the woman had low blood level when she was pregnant, or she is pregnant, with the malaria infection and all of this impact, the level of anemia or low level of blood in her becomes even more worse. And it has a negative impact on the woman, the mother, but also on the child. So again, we have other medical conditions, heart diseases, hypertension, diabetes that can also impact on the life of the mother, but also on the unborn child. Next slide, please. So again, let's quickly look at what are the things that puts a woman at risk of having poor pregnancy outcomes, both for the mother and also for the child. So a risk, it's just the probability that something is going to happen, right? Just the probability that a negative, in this sense, in this context, that a negative outcome from pregnancy and childbirth is going to happen. Right. So first, if you look at the age at which the woman is having her first baby, extreme of age, when you have less than 18, you have a woman giving birth, first delivery, maybe over 35. That woman has more chances to have poor pregnancy outcomes than someone who is giving birth in between those extreme of age. Right? So again, the other thing is the number of babies. If you have so many babies, so what basically happens is with each pregnancy, the risk for the mother and the baby increases. So the risk for the second deliveries might be higher than for the first delivery. But then again, we see these risks mostly when the woman has 5 and then 6, 7, 8. My mother had 8. There were 8 of us. How they survived, we didn't know. Right? So there is grace actually. But then we have knowledge today. Let us not take grace for granted. Is that okay? Yeah, so with increasing number of babies, the risk of poor pregnancy outcome increases. Right? Then again, you talk about interval between births. If births are not properly spaced, if you have short intervals between births, it also increases the risk of having poor pregnancy outcome, both for the mother and for the baby. Find people giving birth, there's spacing between children less than a year. That's really not nice because the woman's body has not had time to recover from the stress of the previous pregnancy. It's always encouraged to have at least 18 months between pregnancies. If you allow 18 months between the last delivery and the next pregnancy, that period is sufficient enough for the woman's body to have recovered and prepare itself for the next pregnancy. So again, there are issues around the physical appearance or physical build-up of the woman. Women who are not so tall. The problem is that a short woman most times will have a contracted pelvis. So she's more likely going to have obstructed labor when she's giving birth. So again, that's why if you visit the facility, all of these things are looked at, and then special attentions are paid to people who have these kind of features. Issues around the weight of the woman before she gets pregnant too. Underweight, overweight, all have their impact on the outcome of the pregnancy at the end of the day. A woman who is obese has an increased risk of developing diabetes and hypertension. And like I had mentioned earlier, diabetes, hypertension are indirect causes of poor pregnancy outcome. A woman who is undernourished has higher risks of giving birth to unhealthy babies. Babies who are maybe preterm, baby who have very low birth weight at the time they are delivered. Low birth weight comes with its own issues, right? They have higher chances of giving birth to babies that are premature and all of those things. So then issues around nutrition. Poor nutrition impacts on the health of the mother and also the health of the unborn baby. Then we have the medical conditions, like I've mentioned, women who have hypertension before they got pregnant, those who are diabetic, those who have heart diseases, those who have maybe kidney or liver diseases too, tend also to affect the outcome of their pregnancy journey. Next slide, please. So what can we do? What can a woman do? Or what can we do collectively to minimize some of these risks to ensure that a woman gets pregnant in optimum health, get very, very good outcome, both for her and the baby, and everybody is happy. Right. So it's important to get regular care before, during pregnancy, before pregnancy, during pregnancy, after delivery, both for the mother and for the baby. So again, if you're planning to get pregnant, it's important to do some preconception checks up. I know it's not routinely done in our settings, but I know a number of facilities are beginning to do all of those things, where you'll get to check your pre-pregnancy health status. So you're screened for diabetes, you're screened for hypertension, you're screened for all those medical conditions. They screen you they look at what medications you're on, because some medicines can affect a woman during pregnancy. See if you need to continue or you need to change or even stop those medications. You also need to protect yourself against getting infections during that period. Preparing to get pregnant and while you're pregnant, right? It's also important to look at those times, to look at your diet. Get healthy diet, balanced diet. And please, I need to make an emphasis here. I said a balanced diet, not an expensive diet. You really do not have to, buy those expensive food items to get balanced diet. Within your small budget, you can have a balanced diet that is going to be good for your own health and the health of your baby. So what about during pregnancy? It's important once you get pregnant to attend antenatal care. Attend antenatal care. And during antenatal care, the health of the mother is looked at. The health of the unborn baby is also looked at. So they're both monitoring you and your child within that period. And it's important to start antenatal care visits early. Most times the recommendation is you start within the first 3 months. Right? And those first 3 months are usually the very, very even critical period in the journey through pregnancy, because that is the period where all the body parts in the baby forms. From the time conception happens, by the time it's 13 weeks, virtually every organ in the body of the baby has formed. So from that moment, it's just growth, 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 until it gets to that period when the baby is fit to live outside the womb of the mother. So again, that period too is critical. And then after delivery, it's also important to have checks too, both for the mother and the newborn baby, because there are critical things that happen within those periods, and we're going to see some of these things in the course of this conversation. Can I have the next slide, please? So let me just talk about antenatal care. Very, very important aspect of the journey of a mother through pregnancy. So antenatal care basically are like the medical care that you get when you are pregnant. At each visit, the person providing the care will do basically check the mother and also check how the baby is growing to ensure there are no issues, no dangers for the mother and no danger for the baby that is growing in the utero. Okay? So the people who can provide you antenatal care, you have specialist doctors, O&G, usually obs and gyn doctors. A family physician can also offer antenatal care. You have trained nurse midwives. A lot of them have the skills and the knowledge to provide those services. A general nurse too can provide antenatal care service. And then we have, in our setting, we have a lot of primary health care centers. And in those places where you find most times are the community health extension worker. A lot of them too have the training, the knowledge and the skill to provide those services. But more importantly, they also have the training to identify danger signs and say, this is beyond me. You have to go to the next level. You have to see a doctor because I see A, B, C, and D. I think we're dealing with this. So you have to go and see a specialist in a bigger hospital. So again, those things are important, right? So again, like I had mentioned early, it's good to start earlier on. It's good to start ANC early. You can start even before 13 weeks, but just start, make sure you start within the first 3 months. And I know the pattern is usually to have a number of visits, but sometimes they tell you 4 visits, it's sufficient for those who are busy, especially if you don't have issues that will put the life of the mother and the life of the baby at risk. So those ones are like focused antenatal care. But traditionally, from the 2nd month is a monthly visit up to the 7th month of pregnancy. During the 7th month, 6th or 7th month, you do a 2-weekly visit to see your care provider. And then between the 8th month and the 9th month, when you expect delivery to happen, it's usually a weekly visit. But for mothers who have medical conditions or who have signs, danger signs in pregnancy, those visits might be more frequent. What I have just described will be for people who do not have any danger signs, right? If you have anything that's going to cause problems for the mother or the baby before she gives birth or when she's giving birth, the visits are going to be more frequent. During those visits too, your care provider will also request some investigations. They're going to take samples of blood, to test the level of your blood, but also to screen for some infection that will affect the mother or the child. They're going to collect urine to test for diabetes, but also to test for proteins, which might be the first indication that a woman is going to have maybe preeclampsia or eclampsia in pregnancy, right? So they also request ultrasound. So ultrasound helps to check the baby generally. Sometimes it gives a clue if there are issues around development. Baby is going to have a birth defect, or there are some developmental issues around there. But there are more advanced investigations that can give all of those things. But at least the least they're going to request is an ultrasound scan. Again, one of the things that your care provider might ask for, it's your last monthly cycle, because it gives information about when your due date will be. So you can calculate when the baby is going to arrive from the last cycle that the woman had before she missed previous subsequent cycles. But ultrasound too can help determine that date. But the most accurate is the last menstrual cycle of the woman. So again, the doctor is going to ask questions, or your care provider is going to ask questions around drugs that you're taking. So there are drugs that generally it's not even safe to take medicines if they are not prescribed by a qualified medical person, right? So there are certain drugs that they might ask you not to take because they might impact the baby, they might also impact the mother. But again, there are also certain drugs that routinely your antenatal service provider is going to ask you to take. And those medicines are fesolate and folic acid. Fesolate helps build the blood level of the woman, or keeps it at the level that is optimum for the pregnancy to progress without issues. Folic acid helps prevent birth defect. So it's also important to even take folic acid earlier. So sometimes, like I had mentioned, the pre-conception care, you're planning to get pregnant, your care service provider might recommend that you start taking folic acid even before you get pregnant. Because folic acid, it's very, very important for the development of that baby in the uterus. So again, there are other issues around illicit drugs. Cigarette smoke, alcohol use, all these things tend to affect pregnancy, the health of the mother, but also the baby. So it's important to avoid those kind of things. I want to assume, yes, okay. So Reverend says it's the other church. I want to assume we don't have people who use alcohol and cigarette here. But then again, I'm also going to advise secondary smoke. You're not the one smoking. You're always in the environment where someone is smoking. That also could impact. In fact, secondary smoke is more dangerous than the primary smoke, because the person who is smoking can hold the thing here and brings it out. But you will inhale it with the air you breathe. You don't have that liberty of holding that smoke back. So again, it's also good to avoid those kind of environment. Stress can also impact pregnancy and outcome, both for the mother and the child. So it's important to take care of all of those things. Can I have the next slide, please? Okay, next slide, please. So again, nutrition, like I had mentioned, is the key thing. So sometimes it's not even taking medicines, but nutrition is important. Get a balanced diet when you're pregnant. And I've mentioned, does not necessarily have to be an expensive meal, right? Just make sure it's a mix of proteins, your vegetables, your whole grains, fruits, and all of those items that we can readily get within our communities, right? So get a balanced diet. Next slide. All right, so again, I had talked about these supplements. The iron supplements, folic acid supplements are also important. Iron helps build your blood level. The folic acid helps to prevent birth defects and all of those things. So those birth defects usually affect the brain, the spinal cord, right? All right, so it usually affects that. So let me have the next slide. So again, before I just delve into this, so during delivery, it's important to have supervised delivery. Make sure the delivery is in the hospital and not at home, except if it's impossible to get to the hospital. Or even if it is happening in the hospital, at home, make sure you invite a trained birth attendant, a nurse, a CHU within the community to come and supervise that delivery so that we have a good outcome. And then after delivery, it's important to attend postnatal visits. So quickly we'll look at the child health care. And child health basically means the care of children from conception till through birth and until when they are 5. So again, I just try to break that period. The first 28 days is called the neonatal period, and they're very, very critical period for the baby. Then you have from 1 month to 11 months, we call the infancy period. A toddler is usually 12 to 23 months, and then a preschool child is between 24 to 59 months. That's less than 5 years. Yeah, so less than 5 years. All right, so again, next slide, please. So let's look at what the problems are for childhood. The estimated number of children under 5 who died in 2020, this information from WHO, it's 5.2 million children, less than 5 years, died in 2020 only. So that means like 6,500 children less than 5 years die every single day. The same area, Africa, Southeast Asia, the same area. In fact, Nigeria has the highest number of under 5 deaths in 2019 in the whole world. So it's our problem. It's big issues for us, right? So again, I tried to break down those 5.2 million deaths. So if you look at those 5.2 million deaths, 2.4 of them happened in the first 28 days of life. That's the neonatal period, the first 28 days of life. And out of these 2.4, 1 million within the first 24 hours of life. Within the first 24 hours of life, those children. So 1.5 million before their first birthday, and then you have about 1.3 between 1 year and 4 years, right? So what are the major causes? Next slide. We have children, deliveries that happen before the pregnancy is term. So preterm deliveries are one of the major causes. You have issues around the baby was delivered, but the baby did not cry. And medically, we call that birth asphyxia. It has a way of affecting the brain of that child. So sometimes when you see children walking on the street, and I'm sure some of us have seen those kind of kids. I mean, the child is maybe drooling saliva. So most times, that's what happened during birth. Baby was stressed during birth, came out, did not breathe. So that first cry is very, very important because that's the period when the lungs of the child opens up, air goes in, and then the baby is able to breathe on its own because in the womb, he gets all the supply, the oxygen and the nutrient through the umbilical cord that links the placenta to the uterus of the mother. That's where the child gets all those supplies. Then the other things are infection, pneumonia, diarrheal disease, malaria, and these are things that are common. Diarrheal disease because we have poor hygiene practices, poor sanitary habits. So it predisposes people to diarrheal disease, especially children less than 5 years are more impacted by that. Then again, the other thing that we need to note is that for all of these factors that mentioned, the underlying, all of this cause, the underlying factor is malnutrition. So whether maternal malnutrition or child malnutrition, they tend to contribute to all of this cost of deaths that we talked about. Next slide. So again, I want to quickly talk about neonatal death because I think those are the critical period. Remember I said the first 28 days of life. But more critical is the first 24 hours of life because that's when most of this death happens. So again, prematurity, like I mentioned, baby that's low birth weight. Low birth weight, when the baby is below 2.5 kg at birth, that's considered low birth weight. Then also things like birth defects that I talked about. So if a child is immature or born preterm, especially before 34 weeks of pregnancy, the lungs has not fully developed. So if that baby comes out, will not be able to breathe. And if you do not have facilities like in a special care baby unit where they will help provide oxygen for that child, the chances of that child surviving are very, very slim, right? So again, you have issues around maybe placenta. So you also have problems around pregnancies, right? If a woman had that high blood pressure that is induced by pregnancy, it's likely going to affect the child. Issues around the umbilical and the placenta rather. So placenta can be low-lying. Placenta can pull off before the woman delivers and all of these things. So these things can also cause that. Infections, like I'd mentioned, and then issues around the baby having difficulties or not breathing when the child is delivered. Next slide. All right, so quickly let's look at what are the strategies that will help a child or a newborn survive. So there are 7 strategies. I think that there are some additions now because these things keep changing. But initially when they were first brought up, there were 7 strategies that were considered by UNICEF. And the acronym is GOBIFF, G-O-B-I-F-F-F, GOBIFF. So G stands for growth monitoring, right? It's important to monitor the growth of the child so that you're able to detect if there are issues with growth. Maybe the child is stunting. He's not growing the way he should grow. For a female child, for instance, if she has stunted growth in childhood, it may affect her reproductive career. Because stunted growth means she may not reach that height we're talking about, and that may also mean contracted pelvis. That may also mean when she gets pregnant, high risk of obstructed labor, with poor outcome for the mother and the child. So it's important to monitor the growth of the child that's going on. Then the other one is, the O is oral rehydration. One of the causes of death that I had mentioned is diarrheal diseases. So this ORS, very, very important. In fact, mothers know how to produce ORS at home. When you go for antenatal care, most times they teach you how to do that. So for your children less than 5, have diarrhea diseases, the first point of call usually is the oral rehydration solution. So it's a mixture of water, salt, and sugar. It helps replenish the electrolyte the child would have lost while in the womb. The next one is the B there. And B basically stands for breastfeeding. Breastfeeding is important. The child gets all the nutrients that he wants through the breast milk. In fact, you don't need to add water. No added supplement. Especially if the mother does not have issue with breastfeeding. Right? And I also need to say something about the first breast milk. What they call cholesterol. Very, very important because it's rich in antibodies that helps protect the child against infection. I know in some cultural practices and norm, they say that's dirty milk. And they don't allow the baby to suck. Yeah, they don't allow the baby to suck that first milk. So again, you're doing the child a disservice by not allowing it to suck that first milk. Okay. So the other thing has to do with family immunization. Also, family planning helps with spacing of your child. female education, it's also noticed that if a woman is educated, she's more likely going to take care of herself, take care of herself during pregnancy, take care of her children, compared to when a woman is not educated. And then food fortification also. So the other things that are added has to do with maybe vitamin A supplement and all of those things. Again, these things keep changing as we get more information about the things that help children to survive. Next slide. All right, so I just put this one just to remind people of the immunization schedule in Nigeria. Usually, so initially we're doing immunization in the first year of life. At birth, 6 weeks, 10 weeks, 14 weeks. Then 6 weeks, 6 months for vitamin A supplementation. Then at 9 months, where the child gets measles, yellow fever. So again, immunization also is, the landscape is actually changing. New vaccines are being introduced. So all these informations will be changing. But what is more important, again, we're also doing vaccination in the second year of life. So apart from the measles vaccination your child gets at 9 months, he gets a second shot at 15 months. The other thing I also need to emphasize is the supplemental vaccination activities that happens. So sometimes you see people come to your houses with vaccines, polio vaccines, measles vaccines, all those things. So those are supplemental doses. And then they help improve the overall body defense system of the child, especially those children less than 5 years. And you'd see that most times when those people visit, they tell you children less than 5 years. Those who are above 5 years, it's believed have developed some form of immunity themselves that their body can fight off infection. So next slide. So let me just quickly talk about some of the things that are on my slide, and then, so for a newborn baby, it's important, the care the newborn gets immediately after birth, I think it's important. So one of the things that I emphasize has to do with the care of the airway. Remember I said if the baby does not breathe, the chances it's insult or injuries to the brain. And then it reduces the overall quality of life of that child when he grows. So at birth, when you deliver in the hospital, the caregiver is most likely going to help clear the airway. Make sure nothing is blocking so that the child breathes very, very well. Sometimes when they notice the child is not breathing well, they tend to give additional oxygen. It's just basically to protect the child at that point. So the other thing has to do with the temperature of the child. So the baby can lose temperature easily. And for a lot of reasons, the skin is not well developed. It doesn't have sufficient fat under the skin that will conserve heat and all those things. So that's why also early breastfeeding immediately after birth is important. When the baby, and then breastfeeding throughout too is important, because when the baby is in contact with the mother's body while breastfeeding, there's exchange of heat, and that keeps the baby warm. But then again, I also need to emphasize in our own climate, sometimes the weather gets so hot. So the other extreme of temperature too can affect the child. The weather gets so hot, and then we put an inner wear, we put a sweater, and then we bring wrapper and cover again. And then we turn off the fan or the AC. We don't want cold to enter the baby's body. Baby becomes so hot, sweats and loose body, what becomes dehydrated, which is also a big risk for the baby. So again, we need to be careful. What, for me, the simple rule is what I cannot tolerate in terms of temperature, then I must not subject a newborn to. That I must not expose a newborn to that temperature. I think we are going to talk about some of these issues in the other section, so maybe I could just leave that. So again, quickly, can you give me the remaining slide? I know my time is off, but let me take 5 minutes. So again, this important thing, how many of us have seen this? That place in the head of the baby that has not closed. Big issue. Please, this is normal. This is very, very critical for the growth of the baby. Perfect for your baby to have this thing. Call it fontanelle. In fact, this is not the only one, because this is the only one we know. But in the actual sense, there are 6 of them. In the actual sense, there are 6 of them on the head of the newborn. Next slide, please. You're going to see where those 6 Right. So look at this. This is like the skull of a newborn. The one we are familiar with is the one in the front. But then there is one here. There is two here. There is another two here. So it makes 6. And all of these spaces have their role. They are normal part of the development of the child. In fact, if this space is closed while the baby is in the womb, big problem. Big problem for the baby. So please, let us not interfere with this thing. There's a membrane that covers that plate. That membrane is tough. Even if you put a nail there, you have to hit hard for it to penetrate. So don't touch it. I know most times traditionally they will tell you, our grandmothers and maybe sometimes mother-in-laws will come and say, "Aya roena chiwonke." The child has headache. The question I used to ask is, how did you know? Somebody who cannot talk, how did you know he has headache? Right? So these are normal. So again, let me just, next slide please. Like I said, 2 key importance of those spaces. So during birth, those spaces allow for the skull bones to move so that the head of the baby can pass through the birth canal. So one bone can lie on top of the other like this when the baby is passing through the birth canal. Once it comes, I know our mothers, traditional Mrs. Kachiro, they know how to handle those head. They know how to press it and then mold it back. Right? So that's important. It allows the head to pass through the birth canal. The second importance of those spaces, it allows for the growth of the baby's brain. First 2 years of life, the brain of a child grows rapidly during the first 2 years of life. So if those spaces are not there, there will be no room for the growth of the brain. Small brain will also mean a lot of things for the child. The child might not achieve his potential in life because he has a small brain and all of those things. So those 2 things, please don't allow anybody touch those places, that particular space for your child when you give birth, okay? Next slide, please. I'm trying to see if I can finish. Time is of the essence. So, all right, so again, just look at this picture. So then, again, the third thing that I want to say about that particular space, it also gives you information about the health status of the baby. So if you see this one, it has actually gone down. So it's telling you that the water in the body of that baby is reduced, dehydration, and it's dangerous for the child. So when you see this, please run to the hospital. For a newborn, even if there is no facility closed, you can start with your ORS, but please make sure you get to the hospital for proper care. The next slide, please. So the other thing you see, it's instead of going down, it becomes bulging. It pushes out. So what that also is telling you is that there's plenty of fluid in the skull of the baby. So it might be an infection, it might be some growth in the brain. And that also is dangerous for the child. So again, let me also say that sometimes when the child, again, I know why most grandmothers would say the child has headache is when the child is crying or is breathing, you see the place also moving. It's also pulsating. So you say, headache. That is normal for that space to pulsate. Right? It's normal for that place to pulsate. But once it goes up like this and it's not coming down, like in the last picture, that portends danger. You also need to take your child to the hospital to get a doctor look at that child. All right, next slide. So let me also talk about cord care. So again, the importance of the umbilical cord is when the baby is in the womb. It gets all the nutrients it wants. It also excretes its waste through the umbilical cord. So that's the connection between the baby and the mother through the placenta. So once the baby is delivered, it's no longer useful. And that's why you cut and you clamp. So again, sometimes people apply all sorts of things. It's usually safe to allow the umbilical cord. Just normal cleaning with spirit, it's okay. Some people go to the extent of applying engine oil, some toothpaste, some even in rural communities, cow dung. Yeah. Kashin shanu. So when you do that, you expose the child to infection, which eventually will kill the child. Because those are some of the things that cause all these neonatal infections that we're talking about. So again, leave the guy alone, the umbilical cord alone. Within 1 to 3 weeks, it will fall off. In fact, most times we advise that for those who use Pampers, don't use your Pampers to cover the tin. Allow the tin to breathe air so that the base will dry off and fall off. But if after 3 weeks it doesn't fall off, then also you might want to see your healthcare provider. There might be some problems. Again, when you see pus coming out, it's a sign of infection. If you touch the place and it's tender, the baby is crying each time you touch, it's also a sign that there's a problem. So you need to go and see your doctor so that that can be addressed. Next slide. Let me quickly finish this. Yeah, jaundice, yeah. So let me just talk about jaundice. Just go next. Next. All right, so jaundice again. That yellowness you see in the eyes of the baby. All right. So again, let me say, most of the jaundice we see in children are normal. They are normal physiological processes. So you have a newborn, most of the organs in the body are not fully developed. In fact, what really happens is that the baby is born, skin not well developed, baby loses some water from the body, the amount of water in the blood is reduced, you have the red blood cells coming together and then breaking. So the red blood cells release a pigment called bilirubin. So that bilirubin is what comes under the skin and under the eyes of the child and gives the child those yellow coloration. And that happens because the liver is still not matured to handle that workload. So the child will have that yellowness, and it's normal. So most times, after 2 weeks, it goes away without really doing anything. But then again, there's also the abnormal one, which may indicate infection. So when you see jaundice in the first day of life, so the physiologic jaundice, usually second day of the life of the baby, you see that appears. Between second and five days. When you see jaundice in the first day of life or after 5 days, then that may be an indication that an infection is happening. And most times the child would have fever. So again, you need to go and seek care in the hospital. Don't try to manage that at home. Don't go and give traditional medications. Don't even give the modern medication. Go to the hospital. Let them look at your child and say, okay, this is what is happening and this is the appropriate care that this child is going to receive. So I think I'm going to stop here so that we can have a discussion of what we have talked about.
Praise the Lord. Please, it's time for question. Anybody that have question? Question. Ask your question, please.
Praise the Lord. Please, I thought you were going to talk about it, but you did not. Tongue tie. I don't know if it's tongue tie or tie tongue. Is it normal in childbirth?
Normal in?
Childbirth, tongue tie.
Any question again? So I'll just put it together.
Praise the Lord. You didn't talk about it, but I think those are some causes as well. I don't know what causes placenta previa.
Okay, big chance already.
Anybody? Anybody?
Okay.
Hello, please, what causes age-prone disease in children?
Sorry?
Is it age-prone disease? Yes.
I didn't get that. Hirschsprung's disease.
That is all.
Okay, any other one?
Any other one?
So, all right. So, thank you for all of these questions. I will make an attempt to respond to the questions. And again, just to mention that we're a team, so other team members can also contribute to the responses. So, the first one is a question around tongue tie. Is it normal in childbirth? So, again, tongue tie basically is a tongue that is tied. There is a membrane under the tongue, right? So for children who have tongue tie, that membrane actually has grown beyond where it should get to. So the tongue stays in the floor of the mouth. It does not allow the tongue to move like other normal babies or other normal people will be. So again, just like you said, that is not normal, right? So maybe it might be part of some developmental issues during growth in the uterus. So basically what is usually done for tongue tie is just to take the child to the hospital and then slit the extra membrane that is holding the tongue there. And then that baby is okay. Yeah. Sir? It's not a prayer point, sir. It's not a prayer point. All right. Okay? So the second thing, the question is placenta previa. So let me just quickly describe what placenta previa is. So placenta previa simply means placenta that it's lying low. Usually the placenta will lie at the upper part of the womb, what we call the fundus of the womb, right? Most times upper at the back, posterior side. That's where, but sometimes it could be at the anterior, but as long as it's up there, no problem. But when the placenta lies at the lower part, the danger is the lie-lowing placenta can cover the opening of the womb. So the implication is this. I know they are graded, so let me not bore you about the grading. It's grade 1, 2, and 3. Right? So the implication is this. If the placenta is lying low, chances are that the woman can bleed during pregnancy. So if it's the type 1 previa, it's not a problem. Small bleeding, sometimes spottings and all those things. But then again, if you're pregnant and you're seeing those bleedings, it's not something, even if it's spotting, it's not something to stay at home. You need to go to the hospital to get evaluated, so that they will do a scan and see the position of the placenta, and your healthcare provider or your obs and gyn doctor will be able to tell you whether it's going to be a problem or not. The type 2 usually comes to the mouth of the womb, but it does not cover it completely. So that will obstruct labor, but also that could obstruct labor, but it also increases the chances of bleeding during labor. And then the type 3 is the one that has completely covered the opening of the womb. So when you have type 3, magana normal delivery, labor and delivery, betashiba. The option you have is cesarean section. So they do cesarean section and bring out that baby. So I don't know. The other third question. Okay, Dr. Jerry wants to respond. Okay. I forgot I was having.
Yeah, so thank you for answering those other questions. I think, you forget that some of us are medical doctors, but no longer doing clinical practice. So the big question was Hirschsprung's disease. And that is a congenital abnormality, actually. So they call it congenital megacolon disease. So it's not something that is common. When you say congenital, it means a problem that is arising even before the child is born. So the child is born with it. Now, normally the large intestine has nerves that make it contract and help someone to pass through. So sometimes in the developmental process, you may have those nerves that actually are supposed to be there, no longer there. So they didn't develop. So that large intestine of that baby does not have the ability to contract. It just remains lax. So the baby is not able to pass through when they are delivered. And the only cure for it is surgery to fix the problem. So that is the issue. So it's an abnormality developing during the baby's development in the womb. So, and we can't tell you what exactly is the cost. Sorry.
All right. So thank you so much, sir. So I have one other question here. The person said, for safety purposes, is it good to give your child some medication beforehand, e.g., ORS, vitamin tablets, and other drugs that parents commonly give children, even if they are not sick or are healthy? So again, like I mentioned earlier during the presentation, what your baby needs, breast milk. If it does not need any other, in fact, not even water, because the amount of water in the breast milk is sufficient for the child. Breastfeed your child normally, and it helps the child. It protects the child even from getting sick. So there is no need to give ORS or to give vitamins or give concussions or herbal medication to your child. As long as the child is okay, all of those things are not necessary. But like I had mentioned, if your child is having diarrhea, right? The advice is go to the hospital. But if you do not have the hospital close by, you can start those home remedies while you are preparing to get to the hospital. I hope that helps. Okay.
Sorry, just to add to that part, I think, so the breast milk is sufficient for the child for the first 4 to 6 months of life. No added food. Just breast milk alone. And you know, mothers always worry, breast milk, he needs water now, he'll be dehydrated. 70% of the content of the breast milk is water. The other ones are nutrients and antibodies, hormones, things that will help the baby to be strong in terms of immunity. So it's only when they are like at 6 months that you now begin to add other formula, particularly things we talk about, Cerelac and those other nutritional things. Again, not solids yet. You are trying to just make sure the baby can manage those. But the breast milk still remains until at least the baby is 18 months. Don't stop breastfeeding until at least 18 months. So baby friendly actually tell you 2 years. No, truly, baby friendly is 18 months to 2 years. And our mothers in the past used that for family planning. They breastfeed for 2 years. Actually, that reduced their ability to have ovulation. So that reduces that. So they can actually space their children with just good breastfeeding. So that is critical, but nothing less than 18 months. If you will not reach the 2 years, just get that. But along with other nutritional things that the baby grows. So as they get older to 1 year, they can begin to add like solids and other things. But generally speaking, the first 6 months, only breast milk. I know you're looking at me funny because you didn't follow that prescription. I know the fight we had with you all those years as my little sister, so I know. But really, truly, you need to, okay? Then the other bit about in terms of the first breast milk you mentioned. So people really worry about the color. It looks like just 2 or 3, not looking like breast milk, so they think it's not good quality, but actually it's the highest quality breast milk in terms of protection for the baby, in immunity that the baby will get to fight the common illnesses that they face as children. So all those habits of trying to take them off, please, let's make sure the baby gets that milk. Let the baby be the first to suck the milk and get it as it comes, the way it is. Don't worry about that. Then for the diarrheal disease, even when we say you can give ORS, you know, preparing ORS has to be under aseptic conditions.
Yeah.
Being clean enough is another problem. So, and that is why sometimes we talk about boiling water and letting it cool after you've washed the dishes that you use to, or bottle you use for the ORS. Then you can now make the salt sugar solution and then provide. But the best thing really, no matter what, if the child is having diarrhea, go and see your doctor or your clinician. Let them really tell you what to do. The danger in pre-medications from home is that you may have given the wrong thing already, and that can be harmful. So seek the medical advice. I think it's always, you're safer that way. That's my thought. So thank you.
Thank you so much. So one more hand here.
Yes, sir. My question is, please, what are the advantages and disadvantages of CS? That's one. And then, is it okay for Christian women to have CS, or must they give birth like the Hebrew women?
Okay.
Sorry, sir. I don't know why they are laughing. In the course of work, people come and they say they're to go for CS. And they'll come and meet me and say, let's pray. Because a Hebrew woman, they should not do CS. So let me know, sir, so I can know how to
pray. Okay. So I think it's an important question. The little time I had spent in clinical practice, in fact, I still remember this incident clearly. I was a house officer. My firm was on call and labor room. When I just resumed, after the morning duty, I came at 6. Then I met this couple at the gate, Christian couples. The wife was in labor. And some of the issues that I had mentioned, all those physical examinations, unfortunately, the wife was involved in a car accident and she fractured her hip bone. So what that basically means, that hip bone was contracted. And all those physical exams were done, and doctors are taking note of that. So on her file, it was boldly written, CS. Boldly written, CS. So when we came, she was already in active labor. And then we looked at the file. In fact, I drew the attention of the resident doctor. I said, in fact, it's not even emergency. It's elective cesarean section. So he now said, okay, just fill lab investigation form. Let's do all the necessary tests. So I gave the husband the form. I filled the forms, I gave the husband, and then he collected it. So all the while, they didn't want the CS. They had spoken to their pastor, and the pastor said they were going to deliver like the Hebrew women. His wife is going to deliver like the Hebrew women. So the man left the labor ward, went round the hospital, and then he came back and met me. So I was like, what's the result of the investigation? He now said that it's not ready. Unfortunately for him, the lab result request form was like this in his pocket. And so I said, what is in your pocket? Lo and behold, it was the lab request form that I gave him that was in his pocket. He didn't go. So we had to explain to them the implication of everything. They signed against cesarean section, and we allowed the woman to continue labor. I met the woman in labor 6 p.m. By 6 a.m., when our call was almost done, the woman was still in labor, active labor. Labor is not making, there was no progress in labor. And by 7 a.m., we had to go eventually to the theater to do a cesarean section for the woman. So all the pains the woman had gone through for 12 hours, having those uterine contractions, was avoidable. Because clearly there were issues. We can't give birth on our own except through cesarean section. So she suffered for 12 hours and didn't give birth like the Hebrew women. She gave birth through cesarean section. So again, there are indications actually for cesarean section. So like this one that I talked about, clearly during antenatal care, it was picked that the woman would not be able to give birth by herself. So she was planned for elective CS. Don't even punish yourself. Once you're 37 weeks, gather your things, come to the hospital, we'll do a CS for you, and you take your baby home. All those things. So, and like I said, there are indications for cesarean section, right? Medical indications. So if a woman had had a previous cesarean section, because like this woman now, she has had a previous cesarean section, but has medical indication or gynecological indication for cesarean section, cesarean section. The best thing for her is the cesarean section. So if a woman has had 2 previous cesarean sections, most times medically they will tell you the third one, CS2, because you want to avoid the risks of uterine rupture when she is in labor. You have cut that uterus 2 times. So the wall of the uterus is kind of weakened. So there is a big risk that if she goes into labor, that place can open. And when uterus ruptured during labor and it's not picked on time, it's going to cost the life of the mother and the baby. Yeah. So there are other indications. If you're having a very big baby, like, so during pregnancy, so mostly women who are diabetic tend to have large babies. So if you have a baby that is 4.5, it's punishment to allow the baby to go through the normal birth canal. So for those ones, it's easier. Do a cesarean section and save everybody pain. Save the woman pain, save the baby pain. So again, because if you allow those kind of labor to even happen, the risk is that that asphyxia I talked about could happen. Baby may not pass easily. Baby gets stressed. In fact, sometimes baby goes into distress while still in the womb. And when that happens too, you have to go and do an emergency cesarean section. So there are a lot of indications for cesarean section. And I know a lot of people are even opting for cesarean section. They don't want the pain. They are okay, they are normal. Just do a CS and let me rest. So those are the things. The only danger, I know Dr. Jerry might add more to that. The only danger sometimes for cesarean section, if you fall in the wrong hands, people who do not have the skills to do that kind of surgery, then it also pertains danger for the mother and the child, and all those things. So again, that's why it's encouraged, go to the right places. Don't go to all the quacks and all of those things that will put the life of the mother and that of the baby at risk. So again, medicine has advanced. There are a lot of technology, right? I know in the past, if you have an indication for surgery, you will have to open your abdomen to do the surgery. Now, small hole, maybe 2 or 3 holes, they put all the telescopes, and they do your surgery for you without having one big scar on your abdomen. So again, technology is improving, and we're having advances. So it's good for people to embrace some of these advances. There's nothing that says you have to, and maybe I'll leave Dr. Jerry to address the Hebrews women part of the conversation, but you can also add to that discussion.
Thank you very much. So I think for me what's important is when it comes to scripture, we always say context is king. What was the context of the Hebrew women? If you remember, they were not the first Hebrew women in the Bible, right? Yeah. These ones were under that burden of slavery, where Pharaoh had now said if they give birth to a male child, the midwives should kill. Yeah. And God just enabled them to deliver swiftly and in a timely way and normally, just to avoid the crisis of having your baby killed. And so the Egyptian midwives could go back and say, hey, before we even arrived, they had delivered, so we didn't even see the baby and all of that story. So that's why you can't blame us for not handing the babies over to be killed. So there are different reasons. The context is very critical. Before then, were women not delivering? And were they not having normal delivery? And even amongst those Hebrew women, are you sure that 100% of them delivered normally? They didn't need medical intervention or midwife's intervention that time. We don't know how advanced their medicine was. There could have been a handful that needed intervention. So the desire of every parent is to have delivery through normal means. Less complication, no trouble. And believe you me, it's the same desire for the physician or clinician who is taking care of a pregnant woman, that you have normal delivery. Cesarean section is not the normal way of delivery, right? So we all agree. But it only comes as a solution when there are problems that tie you as a woman from having a normal delivery without complications, first of all, to the baby, and then secondly, to yourself. So you've said a lot about the complications to the baby, where you want to force a normal delivery where the condition is not favorable. So the asphyxia and the baby having trouble. But you know, the pressure on the woman's sciatic nerve, the vagina and the bladder, where she can have vaginal fistula, and she begins to bleed, leak urine the entire life. A lot of women that are smallish, particularly in northern Nigeria, you know we have a lot. And I think parts of Benue State, where you have those short women too, similarly, that end up with this fistula, and they are leaking urine their entire life. The husbands just neglect them. They are no longer important. Meanwhile, they wanted normal delivery by all means. When ideally you ought to have had a CS, take out that baby and reduce the stress for yourself and the baby. So there are other complications, again, that could happen in trying to force a normal delivery on a mother. So when the clinicians review you and actually look at everything about allowing normal delivery, they found that it can't work. They will tell you, look, the only option for you is let's do cesarean section. And then there are times that it's an emergency. Not because there's a problem with the process of normal delivery, but the baby has stayed too long, the fluid there is not enough, the baby is in distress. If you insist on normal delivery, your baby will die in the next hour. So it's better we go for CS, which will get the baby out within the next 30 minutes, and the baby is safe, and you are fine. So at the end of your 9 months, you don't end up with a dead baby. Simple. So that could also be an indication for a CS. So there are different reasons why clinicians offer cesarean section. Faith does not mean I must have it my way. Faith also means trusting God's way eventually. I want it this way, just like Jesus said, Lord, if thou wilt, let this cup pass me. Right? But nevertheless, your will, not mine, be done. Right? So it's also part of faith to say, hey, I want normal delivery, Lord. But if it will not be, let me go through the other way as long as I will be healthy and the baby will be healthy at the end. And that is where the CS comes in, because even the physician is looking at helping you deliver normally. It's just that it can't happen, and he's saying, okay, look, from what we see, the knowledge God has given us, which again is God giving us that knowledge. Before then, many people lost their children and actually their wives. During that process, because we didn't know how else to deliver the baby. But cesarean section has been a lifesaver. Now, some disadvantage is that there could be some complications, which again, even normal delivery has complications. But then for the couple, it will be more expensive, because once they do surgery for you, you know that you're going to pay more money. So that may be a big deal for the couple. So some people really don't want it because they are thinking also of the cost. It's not just faith. It's like we have to have this baby normally because we cannot afford if it goes to theater. But as I said, for me, the summary is simple. Trust God. Enough to say, if God has revealed to the doctors that the only way we can deliver without complications and trouble for myself and the baby is through cesarean section, why not? Let's go ahead. So that's my thought. Thanks.
So thank you so much for those additions. I think time is fast spent.
Thank you, sir. Call on Daddy for announcement and closing prayer.
So I was asking a question and people were laughing. You can see why I was asking my question. So first of all, let's thank God for today. I think if there's anything or some of the things we've learned, we've discovered that knowledge is power. Knowledge is power. But even in this knowledge, we've learned some things. For those of you who are praying to have children, please take these things that have been shared. Very important. Please. The Bible says in time of ignorance, God overlooked. There's plenty of information now, so you cannot claim ignorance. That. The second thing I want to talk about, when I see this kind of gathering, how many, let me see the number of men who are here. Men. Potential husbands. Those ones are still praying. Let me see. Praying for children. You raise your hand. Your two hands, safe. Praying for children. Those people praying for children. You see, why I'm saying so is because, in as much as they talked about the roles, as I was sitting down there, I was thinking of what role does the husband play in helping the wife through this pregnancy time? Taking her for antenatal. Asking how she is. Some people don't care. You're pregnant. It's like it's your load. It's like it's your load, you know? So I don't know how we encourage our men to be there to help us, okay? I'll also ask that the slides, I don't know if it will be possible, so I'll put it on the church group, so that if you missed anyone, you can just get the whole thing, and then you can have all of that. But then lastly, as children of faith, I think we have to seriously, heavily, for those of us who are alive, thank God, because some of the things they talked about, hey, God has just been good to us. In fact, the one that shocked me was when they said in the Western world, they do 20 weeks. In our own, we do 28. So God helps us for 8 weeks because we don't have facilities that God has already done for us that we can just answer for ourselves. Thank you very much, sir. Tomorrow is going to be more interesting. They are doing meats. I don't know whether that's right. Meats and harmful traditional practices. I had one today. Taking engine oil. I was rubbing my oil. I said, God, thank you. Engine oil. I can't even think how do you do that? So we're going to talk about all those meats tomorrow. So let's invite others, those of us who are here. If you finish giving birth, thank God, you have relations, don't you? You have younger ones that are not yet married. Mommy catch, they are expecting grandchildren. Your daughter is going to give birth. You don't know the in-law that is coming to your house. So know your own now so that you teach your daughter, you teach your son, so that one strange person doesn't come and bring some things that they are and begin to confuse your family. Right now, 2 people who gave birth, 2 of them now, they are doing jaundice medicine. And when he was talking about jaundice, I said, I wish they are here to see that maybe it's just normal. But they've sent me messages, pray for us, sir, jaundice. I said, okay. Now they are telling me that jaundice is just normal, it will just clear. So I'm wondering, should I pray or I should just wait, let it clear? You see? Do you understand what I'm saying? So you see the pressure that sometimes one is on. Now I know. So if you call jaundice, I'll say, talk to doctor. Let me know first whether I start praying or I should just wait and things will be normal. Do you understand what I say? Why I say knowledge is power. And don't underrate any small knowledge. You see, what you have learned here, you may never get it anywhere. You will pay, what if Dr. Abba was going to give this lecture? Even if his wife will be happy, go, spend the whole day, because she knows what will come back. But now it's only prayer. I'll pray for him and say, God bless you. And all of you got it free. Is that not so? Please, let's come tomorrow. Let's invite others. Let's come on time so that we'll have more time to talk. Let's rise together as we pray. Oh Lord in heaven, we are grateful for the wisdom and the skill you've given some of your children who have put this meeting together, who have brought things for us to learn. We're very grateful that, Lord, it's just wonderful what you have done. We're also grateful of your greatness that we have seen. This whole pregnancy thing and all the complications and everything. In your greatness, you work out everything to your glory. We're very grateful that the complexity of our body that we've just seen a bit of today just tells us that indeed there's a great designer and a great creator who has given us life. Lord, we are very grateful. Thank you for what we have learned. Thank you for your son. Thank you for what he has taught us. We ask your blessing upon him. We ask that as they prepare for tomorrow, please help them, that they will be able to again enlighten us and prepare us for the challenges we face around us. We pray for those who are expecting, praying. Some are praying, they're not yet married, but they are trusting you that in the days and the years to come, they will get married. When childbirth time comes, Father, glorify yourself. Let the mother be healthy, let the child be healthy. Whatever complications, we know you can take care of them. But we pray at the end of the day, Lord, this that we have learned, they will apply to their lives. that they will have healthy children and the mother too will be healthy. Provide for us